Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
I'm excited to introduce to our listeners Dr. Neil Tuttle, who is a senior lecturer in physiotherapy at Griffith University in Queensland, Australia. Dr. Tuttle has 40 years of experience in both teaching and clinical practice with a focus on musculoskeletal conditions. He has given more than 30 presentations at national and international conferences and authored 10 publications and 3 book chapters in the past 5 years. In teaching, he is interested in how refining communication, clinical reasoning processes, and manual therapy skills can be used to optimize treatment effectiveness for individual patients. His research interests include the reasoning processes that lead to individualized treatments, quantifying individual responses, and how research designs can be developed to investigate the assumptions underlying reasoning processes. Now that we know a little bit about our guest, let's get to the interview. My name is Steve Shaffer, and I'm here today with Dr. Neil Tuttle. How are you doing, Dr. Tuttle?
Very well, thank you.
It is excellent to have you with us today. I understand that you're currently in Australia. Is that correct?
Well, I certainly live in Australia, mostly on the Gold Coast, but I'm in Canberra at the moment.
Excellent. So we've invited you here today because you were the primary author on a recent synthesis of the literature. It was published in Musculoskeletal Science and Practice. I'm going to give a read of the title here for our listeners. It's called Spinal PA Movements Behave as If There Are Limitations of Local Segmental Mobility and Are Large Enough to be Perceivable by Manual Palpation. So in reviewing the manuscript that you had published, I've noticed that you've participated in some of this research for a number of years, perhaps about a decade. Can you, based on that experience, give our listeners an idea of the general available evidence on this topic and what it says about clinical practice?
Well, I think a number of people have been looking at this question of what happens when we do these techniques. And that goes back probably to the 1990s. And when people were doing those things, they weren't finding the kinds of relationships that were expected. So when they looked at PA movements in symptomatic individuals or in symptomatic situations, they didn't find differences from a normal population. And I think what was happening there was that, if I dare say, they were looking in the wrong place. The idea was that you were looking at end feel and looking at the end of range aspect of the movement, whereas clinical experience to me suggested that it was the early parts of the movement which gave you the clearest information, at least initially.
So for the point of clarification, can you talk for a minute about, when you use these terms, end of range, et cetera, are you talking about the end of the, for example, posterior to anterior application of that joint technique, or are you talking about the end of a physiological range?
What I was referring to was the passive, so-called passive accessory movements. And we still call these passive accessory movements, but they probably are still predominantly physiological movements. We're just using a translational force in order to produce the movement rather than using a rotational force as you would tend to use with a passive physiological movement. So no, I was talking about what you're feeling when you're doing a translational force as a PA particularly.
And I thought that's what you were saying. I just know that sometimes people use these terms slightly differently and they can be, either interpreted different ways or misinterpreted. So I wanted to make sure we were on the same page with that. And it makes me automatically think back to the title. And this is superbly interesting to me. You're talking about how the movements behave as if there are limitations of local segmental mobility. So, that's what you were just talking about, right? Like we think thing A is happening, but it turns out based on the evidence, thing B actually seems to be happening.
Yes. And we don't really know whether there is segmental limitation of movement. If there is segmental limitation of movement, we don't know how it's produced. Predominant theory is that it's muscular. I think there is local limitation of movement, but I don't know what limits it.
To me, this is such a fascinating topic in conversation, which again is precisely why we wanted to have you on the podcast. I have, at this point, 15 years of manual therapy experience, and I know what I feel with my fingers, or at least I think I know what I feel with my fingers. I find what feels like a restriction, and I work on it. My patients often, not always, get better. But when I look back through all this evidence, which has been very nicely reviewed in your manuscript, it just draws questions into my head. Are my fingers lying to my brain? Is my brain lying to my fingers? Do I have no idea what I think I've been doing? Or, is it actually consistent with what my past clinical practice has indicated? So thank you for making me think about this.
And I agree. I think that's part of what prompted us to write this article. So if we look, if I take that one step further, the predominant theory is that you have a muscular limitation of if these things occur, the muscular limitation. My experience is that the limitation that you get in when you palpate is very precise. You move by a degree or two, and the behavior of the stiffness changes. Now, I can't see how muscle could do that. But on the other hand, these things change very quickly. And if it were structural, I can't see how they could change that quickly. So neither of those explanations really make sense to me. So I don't know what happens. But what I think I know is that there's a relationship between the changes in those movements and the changes in the person's symptoms.
That sounds spot on in terms of my understanding. And, in my head, I've actually always thought it's a combination of ligamentous restrictions and, changes in the neuromuscular control or response. We also, of course, learned that it could be an air pressure thing in terms of the cavitation, say comparing before and after we perform joint manipulation. Sometimes it's just guarding, which goes back to the whole neuromuscular thing. And, you bring up these great points because a lot of it's an assumption.
Yes. And so where this is, I'm stepping ahead of myself a little bit, but where this process is going for me is if these things behave, the PA movements behave as if there's a limitation of movement. And when that changes, that corresponds with changes in the patient's symptoms, range of movement and pain, then I think there's clear implications in terms of treatment. Because if that change in what we're feeling, that change in the PA movement under our hands is corresponding with the change in symptoms, then it makes sense to simply adjust our treatment in order to maximize that change.
And what type of adjustment would you think would be indicated in terms of trying to make that change?
I think those adjustments can be adjustments in direction, in speed, in force, in rhythm, and any of the parameters that we can alter in order to maximize the change in the aspect which we think is related to the patient's symptoms.
That, of course, quickly gets into a conversation about dosage because there are so many. It's actually one of the hard topics to discuss with students who are trying to become physical therapists. And, we tend to think sometimes of dosage as being simple, and perhaps it is with a medication, X number of milligrams, X number of times a day. But in terms of manual therapy, the precision of how hard you push, are you pushing in this direction or slightly different? It's sometimes difficult to quantify.
And I think this question of dosage, there's an assumption in some quarters that the effectiveness is dose related, and that you do X dose with a patient at this time, and then the next time you see them or the next treatment that you apply in that session, you do X dosage and you expect the same response. Whereas I would suggest the patient is dynamic and they're continually changing. And I think that it's appropriate for us to modify what we do on that kind of ongoing basis.
Would you lump that in the category of how, especially in terms of manual therapy, but healthcare in general, is often as much of an art, if not more of an art, as it is of a science?
Yes, but art has principles as well. Art isn't kind of airy-fairy. Art is at least as precise in many ways. So I think it's about process and refinement as opposed to sometimes people think science is knowledge and facts and names. And I think science is an experimental process. And I think that what we do is with our patients on a daily basis is pretty much pure scientific method. We come up with, we have a hypothesis. We think if this is true and I do this, then I expect this. I do this. Does that occur? Does it not occur? Revise hypothesis, modify what we do. So I think it's on one hand, there's an art in being able to apply that, but it's actually pure science.
I agree completely. And this is one of the topics that I like to talk about the most because, clearly it is both a mixture in, the terminology that we use, for example, with our students could be something like, we're working with this patient and this is really we'll use the term, a clinical scientific approach. In this particular instance, it's an N of one because each patient is essentially their own case study. And the way that we change things might seem artful, but it's approached from a scientific standpoint.
Yes.
And then this also reminds me of a term. I believe I first read this from a PhD scientist. He's also an MD, last name of Crosscarry. And he's done a lot of research into, biases, et cetera, within healthcare thinkers, physicians and other individuals. And they'll refer to healthcare as being an ill-structured domain. And all it really means is we don't understand all the variables at play. So we're kind of trying to figure it out as we go along. And that's one of the things that kept popping into my head as I was reading your manuscript.
Yeah. And I think other thing that comes into that is the whole question of paradigms. And I've been around long enough to be able to see these paradigms shift from, when I started, people thought of manual therapy as being very mechanical. And then it became clear that it doesn't quite make sense if we really look at this as a mechanical system. And when we look at paradigm shifts, it doesn't mean that a new paradigm is necessarily better. It just means that it's generally accepted. Because the old paradigm, there were enough cracks in it that some things had to adjust. And a new one was developed. But the new one that's developed isn't necessarily the truth, and it isn't necessarily completely better than the old one, but it tends to be generally accepted.
Those sound like wise words. So one of the things that I noticed about this paper, and I've read a lot of the background research before because these things interest me, but I had never seen one of these biomechanical models. It's a literal physical model of a spine, and you're applying a pressure algometer to it to see what happens. Can you talk about these models that have been used in the past and how they're both similar and different to a real spine?
Okay, so the ones that had been, most of what had been done previously were modeled basically as springs. They were made as elastic structures, both the computer-based models as well as the physical models. So if we look back to computer-based model, Michael Lee I believe it was in the 90s, did this quite nice, very impressive looking computer-based model. But everything was modeled as springs. And if you look back at the literature of people doing PA movement, there's a number of these devices which use springs as the thing that people are looking at. If you're looking at the physical model of the spine, The one that we started with was from a company called Sawbones, which is outside of Seattle. And they made this model for testing surgical devices. And so they would screw surgical devices into them. They would then be able to test them. And I thought this was perfect for what I was looking for. But when I felt it, it didn't feel anything like what we feel in a spine. And then when I looked at the movement characteristics, it was very good at the end of range, but didn't have a neutral zone. So it didn't have that play and low resistance area, which I think is so important to what we feel and what we work with clinically.
It seems very similar to part of what I was thinking when I was reading the manuscript, because, you look at it in a model, clearly it's a model of a spine. If you know your anatomy, you look at it and there's no question in your mind that it's a spine. But then there's so much that seems to be missing from it. But then also your patient's going to be, for example, lying prone, and there's an abdomen that has contents in it. There's a pelvis that stabilizes it on one side and a rib cage on the other. And especially with the rib cage, the flexibility or rigidity of that can feel very different patient to patient. So when I see this, this figure of a replica of the spine, I thought to myself, how can that be the same or different? I don't know, because I've never handled one.
If I'm honest, it doesn't feel very realistic. One of the other things that we looked at was using animal models. So, for example, one of the groups of students that I had were looking at sheep's necks and looking at what the movement characteristics were like with those. And I know, for example, Greg Kowchuk in Canada does a lot of work with pig spines, which I think probably have a more realistic feel than what these physical models do. The other area that I'd looked at was trying to do this haptically, so trying to do this with force feedback devices as opposed to physical models. And I played with that for a few years and did a number of models of cervical spine, then realizing that we don't just use one point of contact, and almost all the haptic devices have one point of contact. So I then spoke with a group in Spain who had multiple points of contact so that you could have thimbles on multiple fingers and model the movement. But by the time we had multiple fingers, them not bumping into each other, the spine with the complex degrees of freedom of multiple segments, and the capabilities of the force feedback, it just became too complex.
If our understanding of what is occurring is so imperfect, how should we go about teaching these techniques?
I studied with Maitland, and as much as he was a great clinician, and I may get in trouble for saying this, his communicating of the field was largely verbal. And I look at how we teach now and how much, at least here, I don't know what's done in other places, but we spend a lot of time with our hands on the students' hands, and we feel through their hands, and we say, see, there. No, not that. Can you feel the difference between that and that? I remember it took me 6 months before I could have any sense of being able to confidently feel any differences in stiffness. But we expect our students now to be able to do that at the end of the first lab.
Yeah, I have a similar recollection about my training, and part of it's, it was long enough ago that it's kind of hard to quantify. My memories, for example, aren't perfect, but I distinctly remember not even feeling wonderfully confident until a couple years out. And the skill set I had then, I guess both knowledge and skill set, is nowhere near as refined as it is now. So I just think back to all the people I was working on, and I sometimes feel bad about it, but you got to get where you're going by practicing.
Yes. And how do we communicate that? Again, I come back to that as one of the big challenges is you and I, we've been doing this for a long time. I know that I can feel things better now than I could 10 years ago. And these things continue to develop over decades, not just years. And yet I would like to be able to ensure that the new physios that are graduating have a better starting point so that it doesn't take them as long to get to where as it did me.
I think that's about as noble of a goal as can exist because, you spend all these years yourself developing a skill set, just like myself and other folks. But when you're, for example, in a university setting, if you have some way to make that more effective and efficient for, X number of students who are graduating every year, your ability to impact a large number of patients, and to be honest, it goes a lot further than that because it goes into, payment systems and tax and reimbursement and things like that, then, you're obviously going to have a much more profound impact on society as a whole. I noticed one thing here at the end of your paper. You talked about, a clinical take-home message. You have a summary of perhaps let's call it a thought process that you think is important for clinicians to have. Can you talk about that for a minute?
What we're suggesting from the findings is that the ability to determine the kind of the appropriate location comes with very low forces. You can almost do it in thoracic spine. You can almost do it by resting your fingers on the person's spinous processes and the slightest bit of a nudge, and you can tell which one of those is less mobile. So that's the first pass. It's a very gentle first pass to see where is the, if I can describe it, the as if, where is the neutral zone smallest? And from there, once you've done that, then it can start to explore. You go, oh, okay, so there's something at C4, there's something at C6, there might be something at C7. I'm not really sure which of these is relevant to the patient's symptoms. So I can then do a little bit more and ask the patient, what's that like compared with that? What do you feel when I do that? Which of those are reminiscent, even if they don't fully reproduce, which of these are reminiscent of the patient's symptoms? And then when I work out which of these are relevant, then can explore that in more depth. And it's that more depth exploration which determines what treatment I'm going to do, as opposed to the early parts, which are where I'm going to do it.
That, sir, is exactly the part of the paper that I was referring to. And, to me, as a clinician, the whole process that you've described is very reminiscent to what I've been through, where initially you just feel like you have to push really hard to feel anything because it's not obvious. And the more experienced I get, I can do these quick passes, gentle force, like you were talking about in the spinous process. And then I hone in now onto, the more localized area that feels like it might be, restricted or symptomatic. And then I explore it more thoroughly. And for me, it was interesting as a manual physical therapist to read that in writing because it isn't the type of thing that I was ever taught. It was just, here are the basics. And then hopefully over time, you pick up the rest of it.
Exactly. And this, I think, is a real challenge, is that often what people have been taught, and I think what people teach, is different than what they do. And it's one of the things that we're trying as much as possible now in our program to teach what we actually do rather than a stylized conceptualization of that. So if I can go back for a moment to the question of clinicians, I have a story which I think is relevant to this whole question. So I studied with Jeff Maitland. I was also fortunate enough to be at some conferences and have other manual therapy experts palpate my neck. So, for example, Olaf Evianth and Maitland, they would argue for hours about what they were doing and whether you could use these rules or those rules, or whether you could do them closed packed or loose packed, concave, convex, or whether. But their hands felt virtually identical. And when they palpated my neck, I would not have been able to tell which of them had their hands on me. And one step further of that, I remember when Evian was palpating my neck, he touched one spot and said, "Oh, that's a bit nasty." And he was able to perceive that before I could feel it as pain. Now, to me, that's what I'm talking about. And interestingly, after a year of studying, I did not have a perception of that, and that surprised me. After a year of doing manual therapy study, that point that you could perceive where there was a symptomatic location before the patient felt symptoms surprised me.
And have you since developed that ability?
Oh, yes. And I think it's critical. And I think we aim to have our students now able to do that and start from that. Yesterday, I was teaching students their first lab on using passive accessory movements as treatment in the lumbar spine. And that was part of the process, is you find these things, find your information very early before the patient feels it, then you explore what the patient feels.
That's completely fascinating to me. And I say that in particular as somebody who's in formal programs studied both the Kaltenborn-Evian method and, the Maitland method. And I've had this ongoing battle in my head about how they conceptualize things in terminology and whatnot. And, I find at this point, all these years later, I mesh both approaches together. I bounce back and forth between them. In some ways, I've, in my own head, created my own version of the two that are a hybrid. And, similar to yourself, years ago, for example, when I completed my formal manual therapy training, I certainly couldn't feel things like that, to feel the pain, the impairment, the pathology, whatever we want to call it, before the patient could tell me about it. And now I have since in the recent years developed that skill set. And I find it to be one of my biggest therapeutic skill sets because, I can build confidence and rapport with my patient because now I'm the person who can feel their problem before they can feel it. So then when they trust me and have that confidence in me, they seem to be more willing to let me implement a plan of care or to do something that may or may not be painful. And, obviously through all the research, which is related to things we mentioned earlier, having that positive, psychosocial experience is important for making people better. It turns out that it matters what happens in their head, not just on their spine as I'm pushing on it.
And sometimes I think the effect of what we do with these hands-on things is, yes, there's a physiological effect, if you will, but sometimes it's, like I think you're implying, it's in establishing our credibility. And it's for some patients, for example, the thing that's going to make the real difference to them is a change in their behavior. And if we're just someone talking to them and saying, "Well, I think you need to do more activity," they'll go, "Yeah, everyone says that." But if they know we know what we're doing, and we demonstrate that both by being able to feel what's happening under our hands, but also to be able to make an immediate difference, even if that immediate difference isn't going to last. The fact of making that difference can be enough to assist in motivating that person to change other behaviors.
That is a spectacular point, and it's actually even a great point to end on. This has been a fascinating conversation. I hope our listeners have enjoyed it as much as I have. So, Dr. Tuttle, I would like to thank you for joining us. And perhaps as this additional research comes out in the future, we can have you back.
Fabulous. I look forward to it.
Thank you, sir.
Great. Thank you.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.